Bismillah ar-Rahim. Now we go to the last session of this esteemed conference, and it's still on radiology about MRI breast. And first presenter is Professor Dr. Najla Abdelrazak, and she's going to speak about indications for breast MRI. She's one of the pioneers in the field, and everybody knows her.
من التكنيكال اللي ورا تعالوا شغلوا الفيديو. حد يجي بس يشغل لو سمحت.
بسم الله. خلاص.
طبعا we'd like to have the chance to thank the organization of this conference. It's a really international conference. And we would like to thank very much Professor Najla Abdelrazak for her enthusiasm in the conference and all the doctors that share this conference. We apologize for not arriving of Professor Pascal for unforeseen reasons. But I'm sure that our Egyptian doctors will give you similar or much better information.
Thank you, Mr. Chairman, for the introduction. We are very proud to have you with us here. طب بيشغلوا الداتا شو؟ This is the last session in our course. Yesterday we covered, we had three sessions in the morning covering the basic how to differentiate between benign and malignant by different imaging modalities, and we had two multidisciplinary sessions about DCIS and high-risk lesion, as well as invasive cancer and the molecular subtypes, imaging and treatment, and we end the day with the intervention. And now today in the morning we cover the issue of screening, and now this is the last session in our course. It will be about MRI screening. Yesterday the technique and how to read was covered beautifully by my professor and colleague Dr. Rasha Kamal. So I will directly go through the indications, and I will give you a brief of the indication recommendation, the ISMO, the ELZOMA guidelines, the European Society of Magnetic MRI Imaging for breast MRI indications. First of all, what do we need for a useful MRI? We need expertise in breast MRI. Breast MRI reading is not for every radiologist. It should be, first of all, a breast radiologist having experience in all breast imaging techniques, mammography and ultrasound. So I don't think breast MRI can be read by a general MRI radiologist. It should be done in the correct timing. It should be high examination quality. It should be correct indications that we will go through in this presentation. Should be correlated with the traditional imaging if you have conflict, meaning that you may go for second look ultrasound. Correlation with a single patient profile of risk and common sense. And also for a breast unit, it should have an MRI biopsy device. طيب, where to do the MRI breast? Again, the breast MRI should be done in the breast unit. Experience in conventional MRI imaging, mammography, ultrasound, interventional procedure, and second look ultrasound, because it's nonsense to do MRI breast and nobody is able to do the biopsy for the lesion detected by the MRI. Should be done at least they should have experience of 150 examination per year, and the MRI guided biopsy should be ready available. The USOMA working group recommendations as regards the technique and timing, it should be done between the 6 to the 13 years of the patient menstrual cycle, even with oral contraception, and also in cases of hormone replacement therapy, at least should be stopped 4 weeks before the examination, in order to avoid the background enhancement and so by these drugs. The MRI, for breast MRI to do, it should be more than 1 Tesla, meaning high field Tesla, and it should have bilateral dedicated breast coil and preferably multi-channel coil for breast biopsy. The examination should be done with intravenous contrast media injection, with few exceptions, and simple and reproducible technique, and as fast as possible. For the indications, staging, first, the most important indication is staging before treatment planning, screening of high-risk lesions, evaluation of the response to neoadjuvant chemotherapy, and patients with breast augmentation or reconstruction. Occult primary breast cancer and breast cancer recurrence diagnosis. Again, these are the recommendations for indications. Again, staging before treatment planning, screening of high-risk women, evaluation of response to neoadjuvant chemotherapy, patients with augmentation and reconstruction, occult primary breast cancer, and breast cancer recurrence in diagnosis. First indication is a staging before treatment planning. MRI is very important for accurate T-staging, accurate tumor size and dimension estimation, to diagnose multifocality and multicentricity, and also to diagnose if cancer is existing in the contralateral breast. For DCIS and invasive breast cancer, also MRI is very important to diagnose the exact extent of the disease. Sometimes we encounter cases of over and underestimation. Also, MRI is the best modality to diagnose the relation to the surrounding tissue, what we call the desmoplastic reaction, and immediately post-operative evaluation. For screening of high-risk women, MRI, it was covered nicely in the previous session. MRI is indicated when having positive mutation, BRCA1 and BRCA2 genes, TP53 and others, 50% risk of BRCA genes and TP53 mutation. In case of positive family history of young, although the BRCA is not tested or inconclusive, with the estimated risk of breast cancer 20 to 30%, also it is indicated. MRI is indicated by the USOMA for when having previous radiotherapy to the chest, including cases of Hodgkin disease specifically, when the exposure occurs before the age of 30. High risk with history of breast cancer should be included in the screening program with MRI. If annual MRI screening is done, ultrasound and are not necessary. This is an example of screening of high-risk women, and we found a ring-like enhancing mass at the periphery of the right upper outer quadrant, and it was proved to be mucoid carcinoma. One of the important, for me, it is the most important indication for MRI is the evaluation of response to neoadjuvant chemotherapy. MRI is a recommended primary method for follow-up of patients under neoadjuvant chemotherapy. It should be done as early as possible to get the information should be done after the first or the second cycle of chemotherapy in order to record the shift in the dynamics. For evaluation of neoadjuvant chemotherapy, MRI does not have a role in assessment of the treatment option. However,